Okay, hopefully we'll have some time for questions at the end, and I'm going to wrap things up with a little bit of a transition to talk about maintenance. Now, like many of the things that we discuss in multiple myeloma, this is not a new concept at all. And I'd like to just highlight a paper from Ray Alexanian that was published more than 50 years ago looking at newly diagnosed patients. Of course, they received melphalan and prednisone, and they did a randomization between observation, more melphalan and prednisone, or actually even carmustine and prednisone. And probably not surprising to any of these, to anybody who's actually given these drugs, it was worse to get this maintenance than nothing at all. And this is really not an indictment of the concept, more that the drugs that were available at the time were not particularly helpful. So later on, there were some other forays into maintenance. The top is a study by Sid Salmon that Jim Berenson published in 2002, looking at prednisone, 50 milligrams every other day versus physiologic prednisone. Did improve PFS by about threefold, but of course that would seem pretty pitiful by today's standards. Interferon really didn't come to much. And then, of course, there's thalidomide. And thalidomide did, in fact, improve progression-free survival used as a maintenance strategy. This is a study on the left by Andrew Spencer, where thalidomide and prednisone was given for a year after auto transplant and did both improve PFS and OS. But then there were later studies that suggested that thalidomide might actually damage overall survival, and the side effect profile really sort of took it away. But really the point of maintenance is that's the sweet spot that we want to extend as long as possible. And once we do whatever type of induction we do, whether it's with transplant or not, we really want to extend this time as long as possible. But in addition, we want to reduce the risk of early death. We would hopefully want to enhance quality of life by actually keeping patients away from more toxic chemotherapy. We want to improve survival, obviously. And one of the things that I think is very true in this day and age, patients, just Tom's case pointed this out, we really want to just keep people alive for the next innovation because that really does happen now. And of course, we don't want to cause any harm. Maintenance should ideally be not something that's going to break the bank for society, and time limited is probably one of the best goals to achieve. So really the modern era of maintenance comes up with CLGB 100-104 that was also run in parallel with IFM 2005. Very similar designs. And then induction followed by an autologous stem cell transplant, and then a randomization if you had at least stable disease to either placebo or lenalidomide until progression. And I think everybody is quite familiar with these results, which showed a really striking improvement in time to progression for the use of lenalidomide versus placebo. And one of the things that was also seen here is that time to progression was quite a bit better than what had been seen with the thalidomide maintenance arm in BMT CTN 0102. Now, one of the other things that happened in this study, because it was a crossover design, is that it looked like it was important to start maintenance within about 6 months of transplant, or you seem to lose some of that benefit. Now, the much larger Myeloma 11 study confirmed this, but it also showed an important concept here, which is if you had to get your second treatment after you progressed, being on lenalidomide maintenance did not impact your response to that second treatment, which was quite important. Now, what about survival? It took a long time, actually, for CLGB 100-104 to show a survival advantage, and that persists even with patients crossing over. But I think that's important to remember, particularly for some studies that are pegged to survival. That's going to be a very hard bar to reach. Now, what about the disadvantages of lenalidomide maintenance? I think there are myriad, and probably one of the big ones all along in the US has been cost. And I still see patients who cannot access lenalidomide for that reason. I think as we get more generics saturating the market, that hopefully is going to change. And then, of course, the side effects. There is about a 25% increase in any kind of infection if you look at all the trials. And, of course, clotting and rash and things like that. Risk of secondary primary malignancies. I think most of the meta-analyses have agreed that the heme malignancies are increased after lenalidomide maintenance, whether there's a transplant included or not. Solid tumors is more of a toss-up. And then, of course, the legendary GI side effects that a lot of our patients endure, which can be managed pretty effectively with cholesterol. But we also know that not every patient benefits from lenalidomide maintenance. This is one of several analyses that just underscores that standard risk patients always seem to benefit from our interventions if you have maybe an intermediate high risk, but really if you have that double hit signature, you benefited some from lenalidomide, but not nearly as much as the other kinds of patients. So what about bortezomib? I do have to nod to Dr. Nuka, who had a quite influential paper that he published 10 years ago looking at a case series of 45 patients with high-risk myeloma who had bortezomib consolidation and then bortezomib included in maintenance. And they showed a very nice 32-month PFS. But, there is some question about whether that's the right mixture for patients with high-risk myeloma. And this is a CIBMTR analysis that came out recently trying to prove whether or not bortezomib included in maintenance made the difference. And at least in this analysis of about 500 patients, it really didn't seem to. So I think this is an unanswered question. We also know that some drugs did not perform very well. This is the ixazomib notification that came out a couple of years ago. While there was a PFS benefit for ixazomib maintenance, there was not a survival benefit, and that drug is really sort of not going anyplace. But if we look at other proteasome inhibitors, Dr. Nuka mentioned Forte, and of course we all know there's a second randomization between lenalidomide and lenalidomide plus carfilzomib for up to 2 years. And once again, this did show a benefit for all the participants in terms of a hazard ratio of about 0.64. But again, it's the standard risk patients who do the best, followed by those with one high risk feature. But the highest risk individuals, and there aren't too many of them in this trial, really didn't appear to have that benefit. So how about length of time of maintenance? Well, we can look at a couple of examples, and one would be Stamina, that was really developed as a consolidation trial looking at either just len maintenance for 3 years or VRD consolidation or a tandem transplant. We all know that if you look at intent to treat analysis, there wasn't any difference between the arms. But a very interesting thing happened because the results from CLGB 100-104 came out at the same time the study was going on. And so patients who were supposed to get 3 years of lenalidomide could go ahead and opt for an additional 3 years. And when a landmark analysis was done, and of course this is not randomized, and it only included patients who were still in remission or stable after that 3 years, but it did look like, again, longer lenalidomide maintenance benefited the individuals who stayed on it. Most, again, the standard risk patients, as you can see on the lower right, with the high risk patients not appearing to benefit based on a 0.2 p-value, although, again, those were only small numbers. But other studies have sustained this finding. There are a number of analyses, including the Myeloma 11 trial again, and this is another one, looking at cut points. So above 3 years of maintenance or beyond 3 years of maintenance seems to benefit in terms of PFS, and even some have suggested in survival. But those patients are going to have more side effects, whereas those with less than 3 years are going to have more relapse of myeloma, and that's a trade-off I think a lot of patients are willing to take those increased side effects. What about anti-CD38 antibodies? Well, this is the Cassiopeia trial that was widely criticized is the right word, but analyzed, saying that there really wasn't any impact of daratumumab maintenance because if you got it in induction, it really didn't make any difference when you got it. But there has been a more recent analysis a couple of months ago that really does imply that daratumumab added into maintenance probably does make a difference even if you have daratumumab during induction. And again, this is one of those features about as we do better with myeloma, it's going to take us longer to sometimes separate out these differences. Certainly there are antibodies for anti-CD38 maintenance, just once a month or maybe even every other month injections. It is covered in clinic, which is nice for patients. There are fewer GI side effects. But there is that risk of infection, and one thing I didn't note here is, of course, we all learned during COVID that response to vaccinations is probably affected by the use of daratumumab. So finally, how about stopping maintenance? Well, we were all, I think, just wowed by the Perseus trial here, with the interesting feature that if you were in the daratumumab side, if you were MRD negative for at least 12 months and you completed 2 years of dara and len maintenance, you could potentially stop maintenance. And so we all saw these sort of eye-popping PFS results for 48-month, 84.3% PFS. But about 2/3 of patients who were randomized to daratumumab and lenalidomide were able to stop maintenance. And of course, it remains to be seen how those patients fare once they've stopped. And probably a better test of this doublet maintenance is SWOG 1803 that we're all hoping will complete this year. This is because the induction is not specified, and so patients then are randomized to lenalidomide or lenalidomide plus dara for 2 years. And then if they are MRD negative at 10⁻⁶, Perseus is 10 to the minus 5, by the way. Then they are allowed to either continue lenalidomide or stop, or continue lenalidomide and DARA or stop. And of course, these results will be very important. And one thing that we did learn, apropos to Dr. Nuka's talk, is about 17% of patients on this trial did not have an NGS sequence that could be obtained. And so this required an additional 400 patients added to the trial. But one thing, again, I just wanted to underscore is whether we're using DARA and LEN as maintenance or we're doing other intensification like in MASTER, we still are not helping those highest risk, ultra high risk patients with 2 or more cytogenetic abnormalities, and these patients are going to need better strategies. So what about the future? There are any number of studies using iberdomide, which may be better tolerated than lenalidomide. This is just one that was presented at EHA last year and updated. This shows that you can, within 6 months of starting iberdomide, really improve your response post-autologous stem cell transplant, and there are a number of studies like they're underway. And then, of course, what about the use of bispecifics? EMN 30 from Nels van der Donk is underway in Europe now that they've gone through a safety run-in with teclistamab and lenalidomide. And this is a very large 1,500 patient study with a randomization to either lenalidomide, teclistamab, or the combination. And this is going to be open in the United States as well. And finally, what about CAR-T to improve or get rid of maintenance altogether? This is BMT-CTN's foray into this. This is a pilot study of 40 patients who did not obtain a CR, who were then asked to undergo an idacabtagene viclucil CAR-T and then receive lenalidomide for 12 months. So this study is fully accrued, and I think we're hoping to see whether this strategy makes some sense with results that should come out sometime next year. So in conclusion, I think we would all agree that maintenance or modern maintenance therapy really improves PFS and probably overall survival. Lenalidomide and daratumumab have pretty solid evidence. The combination therapy or some sort of combination therapy after high-risk myeloma is really a standard, but I don't think we have the right combo yet. And if sustained MRD is the right metric, we're hoping that these studies help us decide that. And finally, I'm sure we're going to see a lot more new agents join the roster very soon. So that is it. And I'd like to ask all the speakers to come back up for questions.